تمام يا دكتور عزام، احنا كده بدأنا اللايف على يوتيوب.
تمام يا باشا. شير سكرين مفتوح صح يا باشا؟
شير سكرين مفتوح. هبعت لك بس اللينك بتاع اليوتيوب.
تمام.
وانت ادمن، يعني اسمه ايه، كو هوست. هبعت لك اللينك.
تمام يا باشا.
تمام. اهو على الشات بوكس، اهو ادي اليوتيوب اهو.
ايوه وصل يا باشا، هو كده دكتور احمد فتح السكرين بتاعته يا باشا.
تمام. حضرتك بس افتح المايك يا دكتور احمد.
مساء الخير.
مساء النور، اهلا وسهلا.
مساء الخير يا باشا.
Are we starting or are we starting?
دكتور ابراهيم فين؟ دكتور ابراهيم موجود يا ولاد؟
دكتور ابراهيم في طياره 10 دقائق وهينزل الارض، يعني هيبقى معانا شويه.
تمام. طب هتبتدوا ولا هتنتظروه؟
لا احنا
Uh,
هنبدا.
تمام. اوكي. طب
who's running the meeting now?
اه
أنا حضرتك دكتور زهرة، دكتور فتوح.
ايوه يا فندم، انا.
أهلا وسهلا.
اهلا بحضرتك.
أنا اسمي I think we can start now. أنا حضرتك أنا اسمي أحمد حازم حلمي. أنا بشتغل في، بس عندي مشكلة إن في زي أوكي. أنا صوتي مسموع كويس؟
ايوه مسموع كويس يا فندم.
لا to the others، يعني الناس كلها سامعاني؟
ما دام انا سامعه حضرتك يبقى كل الناس
كل
سامعين.
المسموع. Okay, thank you very much. Okay. Good evening everybody. أنا اسمي أحمد حازم حلمي. أنا بشتغل consultant surgeon في King's College Hospital in London. وحاليا أنا I'm not locum, I'm a permanent. المحاضرة دي بنقدمها دايما للأكيوت abdominal pain، لأنه it's a very common it's a very common thing. It's literally it's the rapid onset of severe symptoms that is life-threatening symptoms with intra-abdominal pathologies, and it needs surgical intervention. كل المعلومات اللي موجودة, all the information that has been presenting today is actually through the BMJ, NICE, and the Royal College of Surgeons and the American Association of Family Physicians and the OSCE one.
اهلا وسهلا، وشرف لينا ان حضرتك تكون معانا.
أنا عارف.
ويعني
أنا I have
يرجع
heard
دكتور
I
ابراهيم.
have heard تسمحي لي, I have heard the news and Ibrahim Zayat is in the airplane now. He can
تمام.
join us at any time. بس
تمام.
عشان انتوا دافعين فلوس في الزوم, فأنا I don't want to waste the time either for the audience or for the team who's listening or for the people who already paid for that Zoom meeting يعني.
اوكي يا فندم، اوكي
Unless you
اتفضل.
want to wait, I can wait. I don't mind at all.
لا ما فيش اي مشكله، احنا ما فيش مشكله في الوقت خالص. بس اوكي، انا يعني اوكي حضرتك ابدا، ودكتور ابراهيم يجوين us when he's available.
يعني خلينا نمشي مظبوط يعني إذا ما كانش ضايق حضرتك يعني.
شكرا يا
The
فندم.
instance of acute abdominal pain, كل الناس احنا all the team who's or listening in any grade, either you are a house officer or medical student or even a senior house officer or a resident or even senior resident or even middle grade like a assistant lecturer or registrar, you always been having an acute abdominal pain in the ED or in the ER room. It's always between 5 to 10% of all the visits. And actually, all the abdominal emergencies, they include surgical and non-surgical. And that is the biggest problem. And now how can we be able to distinguish between the surgical and the non-surgical cases? It needs a very good skills and surgical skills, knowing your anatomy and the physiology of mainly the gastrointestinal tract while you are in the abdomen, and good history taking and physical examination. These two statements are quite very, very peculiar, because sometimes you can have patients coming with pneumonia and they are presenting with acute abdomen. Sometimes you can have patients coming with something in the inguinal region or the groin region and they are coming with acute abdomen as well. Good history taking and physical examination of the abdomen and also of the back passage, which is the PR, and the PV as well. In the modules, our modalities that we are using for treating any acute abdominal pain, you can see that number 3 is laparotomy and proceed. It is number 3. Number 1, interventional radiology and adult laparoscopy, particularly using a laparoscope. It's not even a therapeutic thing. It's also a diagnostic tool as well. You have to understand that patients who comes to the ER with acute abdomen, they can be very old people. Older people, they are usually having anticoagulation, they are usually having antihypertension, they are usually diabetic. Some people are actually a little bit high BMI, and people are on medical treatment for other medications like rheumatoid or these things should be taking good consideration when you are dealing with those people. Children as well, particularly with children with acute abdomen, it should be seen by the pediatric first, but sometimes they call the surgeons just when refer the child to the hospital, oh, he's an appendicitis, it's an appendicitis. And in fact, it is not. Sometimes it's gastroenteritis, sometimes it is tonsillitis, and sometimes it's just chest infection with pneumonia for children. And it's a very, very common thing. So you need to see the pediatrician to see this child just before we can go ahead and coming down to see the patient in ER. Immune compromise. We have plenty of patients nowadays who are actually on methotrexate for long-term rheumatoid. We are patients who are having renal transplant or kidney transplant or even stem cell transplant or even organ transplant. Those patients are immune compromised. Patients who are actually on corticosteroids long-term. Those you have to take care of them as well. The pregnancy, particularly in the last trimester, or even in the first or the second trimester, when you have a female, and we will see this at the end of the slides, I'm not going to talk about it now. Abdominal pain, it could be located in any of the quadrant of the abdomen. Usually, if I can just present these pictures first, usually from the surgical point of view, we look at the 4 quadrant of the abdomen, the upper right, upper left, lower right, and lower left. And there is also the epigastric region and the periumbilical region. We can see that in those areas, it could be intermittent, it could be sharp, dull, or achy, or piercing. This depending on how you can interpret these things with the patient and the patient's family as well. I forgot to tell you about the child that you need to have the mother or the father, not the uncle, not the neighbor, not somebody who you need the father or the mother, because they are actually where the child is living with them, or even if he's adopted or just only in a foster parent thing, which is not happening here, but sometimes the child is living with his uncle, ammu, or giddu, and you don't know who can tell you everything about him. Also, the pain, it could be radiating from one focal site, and it could usually it's accompanied by vomiting and nausea and vomiting. Depending on if it is sudden onset, it could be a vascular accident like abdominal aortic aneurysm, or it could be a perforation that wakes the patient out from bed. It could be a very rapid onset patient with pancreatitis. In Egypt, it's actually the viral infection for pancreatitis or gallstones, but in the Western world, it's also with alcoholics as well. Mesenteric thrombosis, people who are actually dehydrated in very hot weather, and strangulation. Gradual pain like appendicitis or cholecystitis or even diverticulitis. Diverticulitis is a very common in the Western world, and you have to be careful about this as well. Severity and the quality, location, and radiation, all these things are known. For any gastrointestinal associated symptoms like nausea and vomiting, anorexia, change in bowel habits, constipation and diarrhea, we have also to look at those symptoms prior to asking for anything and looking in our gathering of our history and examination. Gynae and urinary tract, dysuria, retention or frequency or hematuria, gynecologically, vaginal, and also the history of last menstrual cycle, and also the missed period, and also how many pregnancy before, is she living on her own, is she married. This is quite very, very important to ask about this with female patients. The differential diagnosis by the location. Look, usually the generalized pain, we look at perforated viscous, or pancreatitis, or bowel obstruction, mesenteric ischemia. This should not be ignored at all, even if the patient is on an anticoagulant. You have to be very careful because sometimes portal vein thrombosis can present with that. Right upper quadrant, left upper quadrant, periumbilical, right lower quadrant, suprapubic, and others. The most important thing is you have to check, as I mentioned at the beginning, pericarditis, pneumonia, hepatitis, and chronic kidney disease, herpes zosters. All these things should be taken in consideration when you are talking about acute abdomen. Sometimes the patient coming and the pain is actually referred from the back to the front and taking the whole intercostal nerves. This is, herpes zoster should come into your mind as well. This is what we are talking about. In the right side, mainly, people sometimes presenting with cholecystitis, pyelonephritis, ureteric colic. I'm talking about either single organ or double organ. Double organ like the two kidneys, two ureters. Single organ like the gallbladder or the stomach. And pneumonia. You can see pneumonia is quite very important with the upper abdominal pain. In the lower abdominal pain, particularly in females, it's quite very important to know exactly the gynae history. I'm talking about females irrespectively of the age. Usually, nowadays, we are actually any female presenting to ER with lower abdominal pain. If they are child, we do an ultrasound. If they are adult, and actually above 30 years old, we always ask for a CT scan. Testicular torsion is a very common thing with referred pain. Appendicitis, of course, everybody knows about that, and diverticulitis, and renal colic or ureteric colic as well. In the groin, sometimes you have the referrer coming with groin pain, and every doctor in ER thinking that groin, it might be a hernia. But sometimes it might be a hernia or it might be something else. So you have to expose the patient properly and look at for any swelling in that area. Talking about that, what are the lab investigations that we usually do for any acute abdomen? We take a blood sample. Amylase and lipase is quite very important, and also the lactate. The beta human gonadotrophin, because of one thing, for the female, and urine analysis, just only the urine dipstick test, all right, to see if there is any RBCs or any white BCs. Abdominal X-ray, chest X-ray, sometimes we ignore that, but it's quite very important, and we know about that in the perforation. The ABG for pancreatitis and ARDS, and also ultrasound CT or MRI. Some hospitals have got MRI as an acute service, but literally you don't need an MRI as an urgent one unless it is something very specific that you can look for after you have finished all your differential diagnosis. The consensus for the evidence-based medicine, usually amylase and lipase are very important, and they are very recommended, particularly with epigastric pain. Patient with normal white cell count, please do not think that it is not an appendicitis. Even patients with appendicitis can present with normal white cell count and the early presentation. Ultrasonography is the image of a choice, particularly is an investigation of choice for right upper quadrant to exclude gallstones. Computed tomography or CT scan is the image study of choice for evaluating patients with acute right lower and left lower quadrant or lower abdominal pain, particularly in females. according to the location of pain, if it is in the right upper quadrant, ultrasound is the first choice. Left upper quadrant, CT. In the right lower quadrant, we have to do it with IV contrast. In the left lower quadrant, IV contrast and oral contrast. Nowadays, sometimes they exclude the oral contrast and they do gastrographin enema if you want to. We are not using any more barium, so we're using all the time gastrographin because it's quite safer. Even if you have a suspected perforation, if it seeps inside the intraperitoneal cavity, you end up having no irritation to the bowel. Dr. Fattouh? Hello?
أيوة يا فندم.
And I'm just confirming that you are following me.
Yes, yes, I'm here.
Very sorry. هل الساوند is clear ولا في مشكلة؟
أيوة تمام.
الساوند is
كل
clear. Okay.
yes, yes.
بتكلم بسرعة، هل الناس تحب ان انا اتكلم slowly شوية؟ انا ما عنديش مانع يعني، انا متأسف يعني.
لا ما فيش أي مشكلة، بس
Thank
هو
you very
it is better.
Thank you very much. Anyway, the true acute abdomen requires urgent surgical intervention from patients who can initially manage conservatively. Not your decision to go for surgery is the easiest decision. The most difficult one is don't wait and see, but the most difficult one is we should wait just until we have some proper investigations being done, or until we can see what's going on with the patient, particularly when we are having scenarios at the end of the presentation. Data from the UK suggests an experienced surgeon reduces unnecessary admission. I presented myself as the consultant in charge of the surgical assessment ambulatory unit. I am the consultant in charge in this unit at one of the elite hospitals of the King's College, which is the Princess Royal University Hospital, and actually having a consultant from 8 o'clock till 5 o'clock and another consultant from 5 o'clock till 8 o'clock in the morning is one of the best options and the most good quality service for the patients. Because when you have a senior staff next to the middle grade, which I mean one of the registrars or the senior registrars, and when you have a senior staff with one of your SHOs or senior SHOs or house officer, this is one of the safest approach to see the patient together at the same time. Particularly experience and critical thinking in surgery plays a very important role in this relationship. Acute surgical pathology can deteriorate very quickly, and having someone senior with you, it is not means that it's demeaning your experience or demeaning your service that you are provide. It is for your safety and for patient safety and for the hospital safety as well. Vigorous investigations and close monitoring is quite very important when we are asking that we need to see what's the pulse, what's the temperature, which is the news. The news is actually nowadays is actually the pulse oximeter, the respiratory rate, the temperature, and the blood pressure and the pulse. These are quite very, very important for patients to be monitored this way. And pulse oximeter, it is not something it's not a luxury, it's mandatory to do it for all patients. When the symptoms do not necessitate immediate surgery, when imaging has not led to a definitive diagnosis, further abdominal examination by another experienced surgeon can call. I'm asking you to call for help, particularly for acute abdomen. Sometimes patients can come with perforation and he is just masking the picture. Sometimes patients comes mimicking perforation and they are mimicking the pictures because they don't want to spend the night at home. They want to spend the night in a very warm hospital with very good meals. So we have to be very careful when we are examining patients with acute abdomen. Diagnostic laparoscopy, as I mentioned, it is not only useful tool for diagnosis, but it is also a very good tool for what you call it, the treatment. For instance, you go for diagnostic lab and proceed for appendicectomy. Sometimes you end up having a very bad mass in the right side of the pelvis or the left side of the pelvis, and that was already missed by the transvaginal ultrasound of the gynae team. All right, people who are coming with PID, and then you went inside and you see that the appendix is literally normal, but the ovary has already ruptured or the ovary has been tortured, or usually the patient is coming with severe fungal infection or bacterial infection inside the pelvis. All right? And please, please, please make sure when you go for a diagnostic lab and proceed that the gynae team is aware, the gynae registrar is aware, the gynae on-call consultant is aware, because you might need him to come and have a look at the screen while you are doing your procedure. Patients coming with pain, they need to have some painkillers. Morphia is not going to cause any addiction to patients. So please give the patient morphine to ease the pain after you examine him and after you see him. All right? If you're concerned that symptoms would be masked, the examination, and therefore correct diagnosis, it could be missed. I'm sorry to tell you that this is total myth. When I was at your age, when I was at your level of training, we were told, don't give morphine, don't give petadine, but please give the patients a good anesthesia, a good narcotic analgesia, because this is not going to hinder the management, but it will improve the patient's comfort, and the patient should not be in pain. These are the examples of the most common cases of the acute abdomen. As you can see, I have mentioned all of them here, and we'll go of them one by one. Okay? And please remember that the 4 quarters of the abdomen and the anatomy that you are seeing in these quarters. The abdominal source of any acute abdominal pain, usually intestinal obstruction. When intestinal obstruction comes to us, most of you have seen that. It might be a hernia which is obstructed. It might be an incisional hernia. It might be an inguinal hernia. It might be an umbilical hernia. But some of the other common causes is you can see that the patient has the appendix when he was a child, or the lady had a cesarean section, or the patient had a laparoscopic procedure. So you have to put in your mind that there is some adhesions as well. Peritonitis is a very common cause, and it is secondary to infection. When we're talking about that, means that there is some sort of ruptured viscus inside, and you have to keep this in the back of your mind. Hemorrhage is a very common, particularly with bleeding ulcers or even bleeding diverticular disease. Ischemia is also common. Dehydration, atherosclerosis, diabetic patients, all right? Perf DU and perf gastric ulcer, of course, when patients are actually on non-steroidal anti-inflammatory tablets, or patients are actually on long-standing painkillers like rheumatoid arthritis or rheumatic pains, or even some headache. Patients can take some ibuprofen or Voltaren like that, and they can end up with a perforated bowel. Inflammatory bowel disease and vascular conditions are also common for the acute abdomen. As I mentioned, the adhesions and the hernia, and volvulus and gallstones and intussusception are also another picture. You can see on the first picture here, this is actually a case of the dilated comma shape, which is actually the volvulus one. In here is the double barrel thing, is the double circular thing, which is actually the intussusception one. And this is actually like gallstone ileus. This is quite very common presentation. And as you can see, there is no air, or it might be in the big picture. I'm not sure. But some of the patients that are having actually gallstone ileus, they can have some air in the biliary tract. This is the features of, this is a CT scan that shows the features of the adhesions and ischemic changes. You can see that in the adhesions here, small bowel, high grade small bowel obstruction, that transition point are actually apparent in the pelvis here, okay? And it is actually due to adhesions bands. In here, it could be due to, you can see the fluid levels, particularly with those patients with the ischemic changes. Perforation, the most important signal in perforation is air. And you can see that there is air in the abdomen with fluid level, and there is air bubbles as well, as you can see in the previous picture here. There's some air in here in another patient, and some air here in the another patients, free intra-abdominal air indicating the sign of perforation, and subhepatic collection with fluid air level, like in the next picture here. In this CT scan, this patient, you can see that gallbladder has been removed. All right, and the patient is having here, I'm sorry that the slide is not completely apparent. There are free fluid there, and there is also a hiatus hernia here in the top, sorry, in the top above the diaphragm. Literally, this patient is actually having a small amount of free air fluid noted in the upper abdomen around the liver, spleen, and the stomach. There's also fluid noted in the right paracolic gutter extending into the pelvis. That patient went into theater. Diagnostic lab was performed at the beginning, at the start, but actually it went up with a laparotomy and pulled this out and repaired the hernia as well. And you can see that the aorta and the vessels are actually having contrast. This is actually the triphasic one as well. And here in the uterus and around the uterus, there's a big fibroid inside within, and that's one, and the urinary bladder is empty. I could assure you that when you have an acute abdomen, please don't forget to put a urinary catheter for the patient, particularly if he's going for theater. Second category is diverticulitis. Diverticulitis, it's actually, everybody knows that it is some pockets coming out from the colon. It could be also in the small bowel, okay, and it could appear also in the duodenum. So please make sure that the one in the colon is always due to long-standing constipation. You can see that there is some fluid collection, and there is no free gas or drainable collection in evidence in this site. I'm very sorry. At the beginning we thought it might be, but it is not. But there is fat stranding with a degree of small bowel obstruction and fluid levels there. Okay. NG tube here is quite a must because it causes the deflation of the stomach and the upper GIT tract. Inflammation, which is, we started with perforation, and then we had the diverticulitis, then the inflammation, like for instance cholecystitis, appendicitis, or acute pancreatitis, and acute diverticulitis and Meckel diverticula as well. Ulcerative colitis and Crohn's in inflammatory bowel disease may present also with the abdominal pain, which is quite very important in those patients to recognize. In the appendicitis, which is actually the very common thing, everybody knows it's in the right iliac fossa or in the right lower quadrant, all right? It could mimicking some problems with the gynae as well, with the ovaries. You can see here that the patient is having a ficculith and also is having dilated fluid filled appendix. I'm sorry, the arrow is not, yes, it is there, and the ficculus is in another picture there, and the fat stranding there. This fat stranding is a very common thing with the appendicitis, okay? Celiac axis were actually very clear. You can see from the contrast media in there, but no pelvic anomalies is there. You can, in here, there is another patient who's actually having segment 5 and 6 does have some right hepatic lobe, no other focal hepatic lesions. Gallbladder shows a subtle enhancing, measuring 4 millimeter stones in there. Spleen, pancreas, and the upper organs are actually okay. The appendix appear inflamed or hypodense and thickened, all right? And the locoregional lymph nodes are there, no collections. Adjacent terminal ileum also shows mural thickening and exaggerated mucosal enhancements, suggestive of contiguous inflammation around that area. The rest of the unprepared bowel loops are essentially unremarkable. This patient had been presenting with an appendicular mass, and as you can see in this site, she already had another fibroid with multiple calcific foci, and he has been treated. The diagnostic lab went in, and in fact, they put a drain and they came out and they treated conservatively, and the patient had a stage appendectomy after 3 months in this case. With children with right iliac fossa pain, don't forget to ask about sore throat chest infection, flu symptoms in the last couple of weeks prior to presentation. Usually mesenteric adenitis is quite very common. You always have the mother and the father coming with the child, abdominal pain. Unfortunately, in my previous history, when I was a resident, sometimes the pharmacist is giving them some tablets like antispasmodic, some antibacterial tablets, just to antimicrobial for intestinal clearing and sterilization, and ending up that the patient is coming with mesenteric adenitis. Ultrasound in the children and the radiographer and the radiologist should be experienced with pediatric patients and should be experienced with the distinguish between ultrasound. You can see that here is actually, he can measure the lymph nodes, and it is actually quite very easy to recognize, particularly with a radiographer and a radiologist who knows the anatomy in that area properly well, and also with the instrument that he is using as well. Cholecystitis is a very common thing. Patients who are coming with gallstones and thickened gallbladder and pericholecystic fluid, usually ultrasound is the choice, but unfortunately, sometimes it's not available after 5 o'clock. So the patient can come either on the next day, but we do a CT scan just to exclude any other problems rather than cholecystitis. Sometimes the patient comes and presenting with gallstones, and the patient can come and tell you, yes, I had a stone, but I'm just waiting for the procedure. Or the patient can tell you, yes, while I was pregnant, they discovered that I have gallstones, but sometimes it's a quiescent gallstones, and you can't, you have to confirm that with an ultrasound as well. The MRCP is quite very common, particularly if we're talking about any stone sometimes in the duct, but in here you can see that there is no dilatation, no back pressure, so it is just the intra and extrahepatic ducts are non-dilated. And that's quite very important procedure that we do an MRCP for those patients, or ERCP if they are actually presenting with obstructive jaundice. Gallbladder, it can be perforated, particularly with diabetic patients. And in those people, if they are actually old in age, they are having a lot of comorbidities, it is better to do a cholecystostomy. And as you can see, it is already there. And you can see that when we inject some contrast material, that it goes directly into the common bile duct and into the duodenum. And in here with the ERCP, just to try to drain that as well. When we are talking about perforated gallbladder, sometimes when we do laparoscopic cholecystectomy and you don't discover that preoperatively, you might end up unable to ligate the cystic duct. Please put a drain, come out, and in the next day, immediately, you have to book the patients for an ERCP, and the ERCP will detect if there is any leak in the contrast material, and if there's the cystic duct, they're just leaving an ERCP stent. It would be easy for the patient and life-saving for him as well. Pancreatitis, as we mentioned, it's mainly due to gallstones, and this is quite very important. In this CT, you can see one small calculus is in the gallbladder neck, and it could be emeritzi, and it could be just a gallstone. That patient already was treated conservatively. If we try to go in directly like that, it will cause huge damage to the biliary system, particularly if you are in a district hospital or a faraway hospital from a referral base or a referral hospital, because if you have a referral hospital, it's easy for you to manage any complications that might occur in such cases, particularly if you can, mainly pancreatitis, if it is became hemorrhagic, the patient should go to one of the hepatopancreatic biliary unit, because he will end up need some sort of laparotomy and trying to clear all the necrotic tissues, and you can deal with the bleeding as well. But it's quite a very, very serious complication with those patients. And if you please, MRCP or ERCP in due course is always advised in those patients. And you can see that the patient, when you are measuring amylase or the lipase, that it is not improving. The white cell count is quite high, neutrophils is quite high, CRP is quite high. Okay, so this means that the patient is deteriorating and the patient needs to be literally transferred to one of the tertiary centers that deal with pancreatitis, because if this patient can die from septicemia and he needs a proper ICU admission as well. You can see here that the MRI scan, it shows changes consistent with pancreatitis and the peripancreatic fluid. And in here, there was no dilatation of the biliary tree. So this means that the stone it was actually dislodged. It was actually dislodged directly in the bowel. And this patient was literally one of the patients that actually was improving. Some people are saying we need to do the gallbladder laparoscopically to remove the gallbladder first, but if the patient is not good enough, because those patients usually when they present it like that, sometimes they are actually over 80, or sometimes they are diabetic uncontrolled, sometimes they are hypertensive and atherosclerotic. So it is better if we treat the patient conservatively and then bringing again for a second sitting to remove the gallbladder laparoscopically. The last part here is the gynecological cases. Usually when we are doing an appendix, a child who's actually a teenager girl, or even a young girl who's actually living with her parents, who's around 18 years old, 19 years old, you think of appendicectomy. Instead of just doing the incision, please do a diagnostic lab and proceed. And always make sure to do a urine test and to have an ultrasound being done to her, and to have the pregnancy test. Sometimes in the new era, in this world nowadays, you can see patients who are coming, I am identified as John. And when you find out he is not John, he was actually a female. But we need to do the pregnancy test, and we need to do the dipstick test for those patients particularly. I'm sorry, I'm talking about the culture that I am used to for the last few years in my life. But in Egypt, I don't think this might be the scenario that you will face. The scenario that you will face is a young girl who's living with her parents and having her menstrual cycle that has been finished, and is coming to you with a severe right iliac fossa pain. Please do the ultrasound and do a diagnostic lab and proceed. If you don't have a laparoscopy, please do not leave this chance. Send the patient to somewhere else who have the diagnostic lab to do the diagnostic lab and laparoscopic appendectomy. But if you are quite having a senior surgeon with you, it is much better if you have a senior surgeon with you, because sometimes when you end inside, you can see that there is a gynecological problem. Okay, like ruptured ovarian cyst or ovarian torsion or even PID. And endometriosis, because we always forget about endometriosis. In this CT scan, you can see that there's a hemorrhagic fluid around in the pelvis. And the patient came presenting with right iliac fossa pain. It was an adnexial mass, all right? And as you can see, the exact etiology was uncertain. It is likely ovarian, and gynecological assessment is recommended. And when I said that before you go in, before you put your scope in, your laparoscope in, if you please ask the gynae registrar to be with you, and ask the gynae consultant and your consultant to be aware of that. You can see that there is a rim of fluid here, which was noticed by the radiologist, okay? And there is also some rim of fluid there, and actually it was actually a hemorrhagic fluid on this patient. And this particular patient had blood transfusion, tranexamic acid, intraoperatively trying to stop the bleeding, and a lot of washout. This is another one that you can see. It's an old lady with bilateral hip replacement that you can see here, but there is also an inflammatory process in the right iliac fossa. Okay, when we're talking about an old lady, it was a tubo ovarian abscess, which is not an optimal for the assessment of ovarian pathology, so it needs a diagnostic lab. Go inside and look with your scope, and bring a gynae consultant with you as well, if you don't mind. I Infection and sepsis is quite very important. Gastroenteritis, infectious colitis. Usually when you do the CT scan, you find that the colon wall is quite very thick, all right? And usually we had a fight with our medical colleague that this patient is not a surgical patient. He needs to go to the medical team, irrespective that's coming telling you that I have been having diarrhea and gastroenteritis for the last 6 or 5 days. The medical team usually wants to exclude any surgical problem in this acute abdomen. Psoas abscess is a very common pathology, all right, particularly with the presence of TB, okay, and pelvic inflammatory disease is quite always one of the differential diagnoses that you have to put in mind. Hepatic abscess or hepatitis, as I mentioned at the beginning, the upper part of the abdomen, can be one of the causes of the acute abdomen as well. Vascular accidents like aneurysm and dissection is quite very common, particularly in atherosclerotic patients, particularly with patients of lower limb ischemia. Do not forget to examine and do the ankle brachial pressure, okay? Do not always forget to examine that this patient knows if he's a cigarette smoker and what is the distance that he can walk. Is he had any amputee of the toes before? He had any stent been put in the lower limb before? Because sometimes they came in with ischemia, irrespective that even after all these procedures that has been done for the lower limb, that this patient is actually already on anticoagulant, and don't forget that they can always present with ischemic bowel. All right. Abdominal wall hematoma. I have came across 2 cases in the last few years that can mimicking, and it can occur spontaneously or secondary to trauma, particularly with the seat belt or even exercise. You can see patients nowadays in the Western world. I have seen patients with over 70. They are coming. They go to the gym, and when they start doing any cardio or any heavy weight things, sometimes they have ruptured some of the vessels, particularly when they are on oral anticoagulant. The most important thing is you have to do the CT scan. You have to follow them with ultrasound. I would advise you, do not attempt to go for any drainage in this area unless it is actually retroperitoneal or actually intraperitoneal bleeding. You have to start them with blood transfusion if the hemoglobin is low. You have to keep them under observation in the hospital for at least 48 hours. And you have to follow them up with ultrasound. And you usually, please, if the hematoma is quite appearing in the abdomen, do not forget to mark the skin all around to see the extension of this hematoma. As you can see here, these are the ischemic bowel. These are not actually my patients. These are actually CTs that I got it from Google search. And you can see the thickening of the bowel. How does it look like? And you can see that there is no contrast there is no contrast. You can see that there is contrast in the aorta, but there is no contrast in the mesenteric vessels. And this is quite very pathognomonic. Urology cases is quite very important, testicular torsion, particularly in children. And if any testicular torsion that you came across, if you please do the other side. Don't send the child home with one side that you have done, and please take the consent of the parents that you do the other side to fix it. Because if he had one side, he will have the other side as well. And that while we're giving the child a general anesthetic, it is better to do both sides at the same time. Ketoacidosis and uremia is a very common presentation with acute abdomen, and usually the diabetic patients always presenting with that. Patients are actually having ovarian tumors or uterine tumors or lower rectal tumors. Sometimes they have deep X-ray radiology radiation enteritis, and this radiation enteritis, they can come always with acute abdomen, sometimes with those patients. In the renal colic, which is I kept it at the end, you can see that patients coming with right iliac fossa. You can see that there is a stone in the pelviureteric junction here, and the CT scan has also discovered in his that he might have some mild cardiac failures. I have finished my lecture, and I'm quite happy open for any questions if anybody uh, want to ask me any questions. And I'm sorry if I was a bit quick. I know it's quite late for most of you, and the appointment was done by my colleague, Professor Ibrahim Zayat, for this. I
Thanks.
don't
Thank
know,
you.
I don't know, how can I show myself? I'm very sorry. Oh, yes, I can see myself now. Thank you. Okay. Hello?
اوكي 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 دكتور عزام.
السلام عليكم.
دكتور احمد دكتور احمد دي حلمي.
دكتور احمد.
دكتور احمد
أيوة يا إبراهيم،
احنا ابراهيم
وصلت.
زياد.
دكتور ابراهيم.
انا مع حضرتك ما رضيتش
أنا
اعمل
مش
قطع
سامع،
وخلاص بنتكلم.
أنا مش سامع.
ايه في الصوت عندك يا انا مع حضرتك من بعد فتره بدات ب 10 دقائق تقريبا.
حصل
بس ما
خير يا
رضيتش
إبراهيم، أنا
اعمل
عارف
قطع
إن أنت كنت في الطيارة، فأنا معلش، أنا حبيت إن أنا
اه
يعني أمشي بالميعاد بالمظبوط عشان ما نأخرش الناس، بس أنا متأسف يعني.
كالعاده. لا كالعاده حضرتك المظبوط على طول يا دكتور احمد.
أنا
احب
والله
بس
أنا I made every effort to be on time النهاردة، الحمد لله يعني.
I know. انا بس احب بس يعني اشكر حضرتك على المجهود اللي حضرتك بتعمله معانا وعلى البرزنتيشن الهايله اللي حضرتك عملتها. والحقيقه بس يا شباب انا عايز اعرفكم مين احمد حازم حلمي. انا معرفه دكتور احمد من 1998. اول ورك شوب عمله في الانيمال لاب في يوربر هاوس لما دخلنا اشتغلنا على دوجز على الفاسكولار ستراكشرز وعلى الهيباتيك ديسكشن وعلى اللابروسكوب سيرجري كلها. والحقيقه ان هو كان فيري جود تيتشر، ساعدنا كتير جدا. من يومها وانا على علاقه جيده بالاستاذ دكتور احمد حازم حلمي اللي له دور كبير جدا في الكونتينوس ميديكال اديوكيشن في الجراحه في كل ربوع مصر. احنا يعني من حضرتك سعيد ان حضرتك كنت معانا النهارده وتشرح توبك مهم يهم كل الجراحين في مصر وغير الجراحين كمان. شكرا لحضرتك جدا يا دكتور احمد.
محمد إبراهيم ممكن
ايوه
أرد؟
اتفضل يا فندم.
أنا بصراحة يعني أنا معتز بمعرفتك من سنتها النهارده، وأنا بشوفك يعني you are progressing، وأنت راجل يعني بتحاول تدي وتعطي، وده اللي أنا يعني بحاول أنا أعمله زي ما اللي أنت بتعمله بالظبط.
بس
ربنا
هو كل ده
يخليك.
تعليمك يا دكتور احمد.
ربنا يخليك.
تعلمنا منك الكلام ده.
دلوقتي أنا
السلام
أطلب
عليكم دكتور
من
احمد.
الناس حد يحب يسألني يتفضل، أهلا وسهلا.
السلام عليكم دكتور احمد، حضرتك سامعني؟
أنا سامع عليك دكتور عزام.
مع حضرتك يا فندم دكتور ايمن منظور، مدرس الجراحه في طب اسوان ومودريتور السيشن بتاعت حضرتك يعني.
ممكن تعيد تاني؟ أنا ما سمعتش آخر جملة معاك. أنت بتشتغل فين يا دكتور
حضرتك
أيمن؟
سامعني كده؟
حضرتك بتشتغل فين دكتور أيمن؟
انا مع الدكتور ابراهيم الزيات في قسم الجراحه في طب اسوان.
أهلا وسهلا، تحت أمرك.
اهلا وسهلا بحضرتك. مبدئيا احنا بنشكر حضرتك على وقتك ومجهودك في البرزنتيشن، ان حضرتك يعني غطيت كل جوانب الاكيوت ابدومينال بين. فانا يعني
هو
من
حقيقة
المودريتور بتاع السيشن.
البيدياتريك 1 أنا ما حطيتوش، لأنه البيدياتريك دلوقتي وأنا بقولها بمنتهى الأمانة يعني، إحنا الحاجة الوحيدة اللي مسموح نعملها في البيدياتريك الابندسكتومي، اللي هي الرايت إلياك فوسا بين. أوكي، لكن
تمام
أي حاجة تانية
تمام
حولها للبيدياتريك سيرجن. وانا انصحكم وانصح الجميع ان حاجه زي كده تبقى هي ده البراكتس، لان لو عملنا لاباروتومي بيدياتريك بيشنت يعني sometimes things can happen. وهنا في مصر جمعيه جراحه الاطفال بتطلب ده وبتريكومند ده من كل الناس. فانا
تمام يا
متاسف
باشا.
ان انا لم اذكر البيدياتريك اكيوت ابدومن، لان قلت ان ده it's not going to be the subject that will be interest to anybody، لان الحاجه الوحيده اللي مسموح لنا general surgeon to perform just appendectomy.
حضرتك بتتكلم على اللي هو اللوجيستكس اللي موجود عند حضرتك في انجلترا، صح؟
اتفضل يا فندم. ايوه
انا بتكلم، حضرتك بتتكلم على نقطه اللي هو لو فرضا في جالنا عيان اكيوت ابدومينال بين وحضرتك كنت كول، فانت يو كان بروسيد اكسبت في البيدياتريك سيرجري جاست appendectomy.
ايوه.
That's right.
ايوه.
تمام، اوكي. في حد عنده اي اسئله يا شباب؟ دكتور عبد الرحيم دنجل مدرس الجراحه معانا في طب اسوان
اهلا
هيسال
وسهلا.
حضرتك سؤال دلوقتي اهو.
اهلا وسهلا.
السلام عليكم دكتور
عليكم السلام
احمد،
ورحمه الله
شكرا
وبركاته. اهلا وسهلا.
جزيلا على المحاضره الجميله دي. انا بكلم حضرتك من اسوان، انا مدرس جراحه في اسوان حاليا، وكنت يعني حضرت ورك شوب مع حضرتك ومع الدكتور نبيل دويدار من حوالي
اهلا وسهلا.
18 سنه هنا في اسوان عن البيزك سيرجيكال سكيلز، كان
اهلا
مع
وسهلا.
الدكتور نبيل
انا
دويدار
فاكر انا
ايام
فاكر
الدكتور
الوقت بتاع
سعيد
حضرتك
راتب.
كويس قوي. اهلا وسهلا.
وقابلت حضرتك تاني في الاي تي ال اس كورس في 2020 لما حضرتك نزلت من انجلترا وخدته قبل الكوفيد يعني.
اهلا وسهلا.
سؤالي لحضرتك فيما يتعلق بالتورشن تيست. تمام، حضرتك يعني جبت هنت عليها عن بسيط، رغم ان حضرتك بتقول برضو ان بيبقى صعب انك تشتغلها في عدم وجود بيدياتريك سيرجري او كده. هل في
لا،
رول
حضرتك بتتكلم عليه حضرتك؟
على التورشن تيستس في البيدياتريك او
تورشن
الايفن الادلت؟
تيستس، بعد اذن حضرتك، التورشن تيستس اليورولوجيست عاده هو اللي بيعملها،
مم.
لكن احنا كجنرال وما عندكش يورولوجيست حياه الطفل ده عباره عن ولد عمره 8 سنين، 12 سنه، 16 سنه، لما يحصل التست بتاعت الاستمرار. بس نمبر 1. نمبر 2، لو هي جايه في واحد ادلت you have to exclude epididymitis واوركايتس، ودي مش هيبان الا بالالترا ساوند.
يعني حاليا في رول للدوبلر، كان زمان في امتحانات الزمالات وكده بيقول لك if you suspect you should take the
just go
patient
ahead
directly to
just
the
go ahead
OR.
yes
هل
if you
دلوقتي
suspect go ahead.
الجايد لاينز
yes
هل فيها
you
تغيير
are
ان احنا
absolutely
ندخل
right.
الدوبلر فيها؟
انا ما بقولش حضرتك ما تعملوش على طول go ahead. That future, this is the future of this boy to be a young man, a full young man who can perform and you can have a babies. حرام يعني.
اللي انا بسأل حضرتك، هل دلوقتي في رول للالترا ساوند تيستس او الدوبلر
بص
قبل ما
حضرتك
اخد قرار ان انا
بص
قبل ما
حضرتك
اخد قرار او ار؟ احنا في مصر بنعمل كده، لكن
بس
بره كان
انت
الامتحانات
بتعمل في
والحاجات
مصر، تسمح لي
عندهم بيتكلموا انك ما تعملش دوبلر.
تسمح
if you
لي
suspect go direct to the R.
تسمح لي انت في مصر السونوجرافر قاعد جنبك، لكن في انجلترا after 5 o'clock he is not there. after 5 o'clock is not there. وبعدين بعد اذن حضرتك، انت لما بتحط الولد قدامك عمره 12 سنه او 14 سنه and he's completely exposed، بتقدر تعرف على طول مين اعلى من مين، وبتقدر تعرف مين swollen ومين short في الناحيتين. رايت اوريدي الاب والام بيقول لك ده هو كان بيلعب كوره، ده اتخبط بالبسكليته، ده بيلعبوا مع بعض، شاطوه اتكعبل. يعني دي حاجات كلها بتحطها في اعتبارك، اوريدي بتاخد الكونسنت من البيرنتس اوكي على حاجه زي كده. alright.
بالظبط. اوكي ماشي، شكرا جزيلا دكتور.
حضرتك تحت امر حضرتك. الصوت راح، انا مش سامع حد. دكتور فتوح،
الو.
حضرتك
ايوه
are you still running the الميتنج، ولا
ايوه
انا
انا
لان انت اللي
ايوه
ابتديتي معايا، معلش حضرتك يعني.
انا مع حضرتك. كان في دكتور ايمن دلوقتي كان بيقول هو هيز ذا مودريتور، فانا سكت عشان كده يعني.
انا متاسف جدا I'm very
لا
sorry.
مفيش اي مشكله، لا مفيش اي مشكله. في حد يا شباب عنده اي اسئله؟
هو حضرتك احنا هنا في أسوان، يعني مشرفنا الأخصائيين والزملاء كلهم من الاستشاريين اعضاء هيئه التدريس، فهم حقيقي يعني مبسوطين ان الدكتور احمد غطى كل الحاجات الاسبكتس اللي موجوده في الاكيوت ابدومينال بين، ودي حاجات اوريدي احنا بنشوفها يعني.
اوكي،
تمام.
خلي
احنا
بالك إن
بالنسبه
في
لنا
حاجات
يعني
موجوده عندك،
عاجزين على الشغل.
في حاجات موجوده عندك في الجفرمنت هوسبيتال في مصر مش موجوده في انجلترا. يعني انت
زي
تقدر
ايه يا
تطلب
باشا؟
الراديولوجيست، اسمعني بس، انت تقدر تطلب الراديولوجيست لو سمحت تعالى اعمل لنا، اقرا لنا السي تي ده، تعالى اعمل لنا الالترا ساوند دي. انا في انجلترا ما عنديش
اه.
الحاجة دي. ادي اول حاجه. تاني حاجه، انت النهارده، انت النهارده يعني الفرق في التعامل مع حالات الاكيوت، انك انت النهارده بتعمل السي تي، بتنده فلان، بتنده فلان، فلان ده مش موجود، بتنده فلان التاني. يعني دي اوريدي الكلام ده بيبقى موجود في انجلترا بمنتهى السهوله، بمنتهى الاريحيه. لكن انا I have to wait and keep the child under observation or keeping the patient under observation علشان I want to exclude gallstones or to prove gallstones. ليه؟ لأن
اوكي.
الراديوجرافر والراديولوجيست، لا ده أنت شاكك في كولوسيستايتس ما تعملش سي تي، هتعمل الترا ساوند. يعني أنت واخد بالك؟ أنا محكوم بقواعد لازم أمشيها ولازم أعملها. ولو
تمام.
العيان بعد إذن حضرتك، العيان بعد إذنك ما كانش patient ما بياخدش البرايورتي. اوكي، انا بشتغل في مستشفى فيها 4 سي تي سكان
مهم.
و3 ام ار اي. لازم العيان يبقى امبيشنت ياخد البرايورتي.
تمام.
ده
اوكي.
حضرتك. لكن سي مثلا العيان انا روحت اديته كونزرفتيف تريتمنت لان ما عنديش تي ينام عليه، هتكون ايه النتيجه؟
مم.
انه هيتعمل له الالترا ساوند within 72 hours.
مظبوط صح.
يعني 72 hours في اوكي. انت النهارده دكتور النساء، تعالى يا عم شوف الست ديت، لا الست دي حامل، البريجنسي تيست بوزيتيف وعندها رايت ايدك فورسا بين، من فضلك اعمل لنا ليها ترانس فاجينال الترا ساوند وشوف الدنيا شكلها ايه، واعمل لنا بيرفكت الترا ساوند وشوف الدنيا شكلها ايه. اوكي،
تمام.
انا ما اقدرش اعمل لها سي تي، فلازم
مم.
استنى الجاينكولوجيست عشان يجي يعمل لي الشغل ده. فخلي بالك انه irrespective ان انا ماشي على قواعد وعلى restricted regulations، لكن دي بتتعمل for the patient safety عشان البريورتي. انت
صحيح.
بتتميز عندي هنا افضل انه لو سمحت الكونسلتنت الفلاني جاي وهشوف العيان، اعملوا لنا الالترا ساوند قبل ما يجي لو سمحت. خدت بالك؟ ده الفرق. لان
تمام.
انا برضو انا كنت في يوم من الايام كنت كونسلتنت واستاذ ورئيس قسم وعميد، لكن انا حاليا في انجلترا، فانا فاهم القواعد اللي بنتعلم عليها. يعني ما
تمام.
تعتبرش دي نقيصه، لا بالعكس، في بعض الاحيان بتكون منحه وميزه.
بالظبط. بالظبط. شكرا دكتور احمد على الافاده اللي حضرتك عرضتها لنا، وانا دلوقتي مع الزملاء فهم ما عندهمش اي اسئله يسالوا حضرتك فيها يعني. فنتمنى حضرتك تبقى على طول في تواصل معانا، وتشرفنا ان شاء الله في سيشنز لاحقه باذن الله.
من عيني الاثنين، حاضر.
ورمضان كريم وكل سنه وحضرتك طيب.
الله اكرم يا اخي الفاضل.
شرفنا يا فندم.
شكرا يا فندم.
شكرا يا دكتوره فتوح.
شكرا يا باشا. في رعايه الله يا فندم.
البري اللي ورايا ده من الصعيد بالمناسبه، عشان تبقوا عارفين يعني. لان انا اهل والدي من المطاعنه. اوكي،
really
انا
beautiful.
سعيد بمعرفتكم جدا.
احنا عندنا
السلام
كتير يا باشا
عليكم.
من المطاعنة هنا في طب أسوان.
دكتور أحمد.
يعني من الواضح ان في بعض منكم انا شفتهم ايام ما عملنا الدوره التدريبيه في اسوان، ورحنا ذبحنا الجمل في البلد اللي هي شمال اسوان، اللي هي الجمال، او جنوب اسوان. اوكي،
السلام عليكم ورحمة الله وبركاته.
ربنا يكرمكم جميعا. وانا مبسوط ان في طب اسوان، ودي حاجه كويسه جدا جدا. ولو
متشكرين يا فندم.
اي حاجه انا تحت
متشكرين.
امركم.
شكرا
دكتور
جدا دكتور
أحمد.
احمد، شكرا دكتور ايمن، شكرا دكتور زهره.
يا دكتور
شكرا يا
إبراهيم،
فندم.
أكلم دكتور أحمد طبعا عشان
اتفضل.
معاك محي الدين مصطفى مدني. أنا دكتور أحمد عجبت حضرتك
اهلا يا دكتور
كلمتين.
مدني، اهلا
واحد،
بحضرتك.
القصر
انا
عين
فاكر اسم
الفرنساوي
حضرتك
في
بس
المطعمة.
سامحني. انا فاكر اسم حضرتك بس سامحني، انا كبرت في السن فمش قادر اميز الصورة كويس، فسامحني يعني.
الله يبارك في حظك.
لكن فاكر لقب حضرتك جدا كويس قوي.
حضرتك معرفة حضرتك مطعمة التراكي العمدة النوبي.
اهلا وسهلا. لا
أهلا
شوف، انت
وسهلا.
عارفني، انت جبت قراري قدام الناس كلها يعني.
الله يبارك في حضرتك. أهلا
اهلا
وسهلا
وسهلا.
فيك. الله يبارك في
ربنا
حضرتك.
يخليك يا اخي الفاضل، متشكر
الله
جدا.
يبارك في حضرتك. الله يخليك.
انت نورتنا وشرفتنا يا دكتور احمد، والله ربنا
يا
يخليك.
حبيبي، يعني المكان مشرف ومنور باصحابه،
ربنا
وربنا
يخليك.
يكرمك ويجازيك خير الجزاء على كل اللي انت بتعمله.
ربنا يخليك، ونشكر دكتور
وانا
ايمن مبروك
كويت
جدا
هابي ان
على
انا اعمل، لو عايزني اعمل سيشن،
السلام عليكم.
على الجول بلادر انا تحت امرك يا ابراهيم.
ان شاء الله هنتفق مع حضرتك على القادم ان شاء الله.
باذن الله يا ابراهيم، وانا متشكر ليك جدا واتمنى اكون عند حسن
ربنا
الظن
يخليك.
جميعا.
نورتنا وشرفتنا يا فندم.
خير، كتر الف خير.
شكرا يا
السلام
دكتور
عليكم.
ايمن، شكرا يا دكتور زهر.
شكرا يا فندم.
السلام عليكم.
الله على السلامة.
لو سمحت يا باشا.
اتفضل.
عينيا
السلام
مين
عليكم.
بيكلم؟
عينيا، اهلا وسهلا.
مصطفى النمر يا باشا، مصطفى النمر.
نعم،
الدكتور مصطفى النمر مع حضرتك يا باشا.
تشرفنا، اهلا وسهلا.
شكرا على المحاضرة الرائعة مع الباشا.
ربنا يخليك يا اخي الفاضل.
معلش يا باشا، كنا عايزين حضرتك لو تكلمنا عن الفرق بين البريتونيتس والبريتونيزم.
عايز تعرف الفرق ليه؟
لا، اسراء معرفي يا باشا، والله مش اكتر.
انا بسأل سؤال، خليك فوكس. انت النهارده العيان عنده بيريتونيتس، يعني عنده perforation، عنده انفلاميشن.
يعني ايه؟ تمام.
الانفلاميشن اللي عنده ده سببه ايه؟ احنا شرحنا كله. لو ده مش موجود
تمام.
عنده هتبقى بيريتونيزم. It's very simple differentiation يعني.
يا باشا احنا عايزين نستفيد من حضرتك بكل جزئية،
يا
عايزين اسراء
دكتور نمر،
معرفي.
يا دكتور
اتفضل
نمر،
مع الباشا.
يا دكتور نمر، سامحني في
اتفضل
الكلمة.
مع.
ربنا قال لهم بقرة، مش كده؟ الو، انت رحت فين؟ انت رحت
اتفضل
فين؟
يا باشا، موجود مع حضرتك. اتفضل مع الباشا.
انا ولا باشا ولا احزن، بقول لك يعني عشان خاطري يعني ما تصعبش الامور على نفسك. احنا قلنا البريتونيتس weak related، صح؟ يبقى ده لو مش موجود
مش
خلاص
سامع حضرتك يا باشا، معلش.
يا فندم.
البريتونيتس مش الجزئيه الاخيره مع الباشا.
يا دكتور نمر، البريتونيتس عباره عن ايه؟ عيان عنده بريتونيتس، يبقى عنده some sort of inflammation جوه بطنه.
تمام. تمام.
خلاص. and this peritonitis تاخدها بالاناتوميكال structures، ممكن تبقى inflammatory bowel disease، ممكن تبقى appendix، ممكن تبقى diverticulitis، ممكن تبقى ulcer في epigastric، ممكن تبقى gall bladder، ممكن تبقى pancreatitis، ممكن تبقى vascular occlusion، ممكن تبقى ischemia، ممكن
تمام.
تبقى twisted bowel، ممكن تبقى internal herniation، ممكن تبقى volvulus. كل دي قدام حضرتك بتعمل للعيان abdominal acute، ولو حصل منها severe inflammation تبقى peritonitis، ولو حصل منها perforation بتبقى peritonitis. ممكن تبقى localized، ممكن تبقى generalized. localized في حالات الدايبيتس، generalized في حالات الجيوتينال ulcer، stomach ulcer.
تمام.
حضرتك ممكن تبقى في حالات الجول بلادر، عينين الدايبيتيك والجانجليونيك بلادر وتعمل برفوريشن. ممكن تبقى حالات سيفير بانكرياتايتس وتعمل الكلام. اوكي، ممكن تبقى حالات اوفيريان ديس رابتشر وفي هيموبريتونيوم. الهيموبريتونيوم ده از فيري بينفول. جاوبتك ولا برضو ما جاوبتك؟
لا تمام يا باشا، تمام. تمام يا باشا، تعبنا حضرتك يا معالي الباشا.
صديقي العزيز، انا لا باشا ولا انا دكتور زي حضرتك بالظبط.
شكرا جزيلا.
دكتور ابراهيم،
شكرا يا دكتور احمد بيه، شكرا جزيلا.
انا تحت امر حضرتك يا
الحقيقه
حبيبي.
انا مش عارف اشكر حضرتك ازاي والله يا
ده
دكتور
شكر
احمد،
على
بجد
واجب،
والله
ده
كتر
واجب
خيرك يعني.
عليا قبل ما يكون شكر، وده واجب ليك وواجب
ربنا
للزملاء
يخليك
جميعا
يا
اللي
فندم.
عندك. اوكي يا ابراهيم،
ان شاء الله اقدر اشوف حضرتك في اليومين اللي بيكونوا في مصر لو
ربنا
ممكن،
يحيينا ان
لو
شاء الله يا
حضرتك
ابراهيم باذن
في
الله.
وقت مناسب
انا
اشوفك.
حكيت لك الظروف، فربنا يحيينا
ان
ان شاء
شاء الله
الله.
يا فندم.
السلام عليكم يا حبيبي.
ربنا يكون في العون، ولو في اي
نراكم
حاجه
جميعا على
انا
خير
اقدر
ايها
اعملها انا تحت
الزملاء
امر
الافاضل،
حضرتك.
الزملاء
شكرا يا فندم، مع الف
والسيدات، اذا
سلامه.
كان في اي دكاتره سيدات فما ارجو ان ما يزعلوش مني، يعني انا بوجه كلامي للزملاء بس.
لا خالص،
السلام عليكم جميعا.
مبسوطين بوجود حضرتك والله.
وانا
شكرا
اكتر
جزيلا،
والله.
مع الف سلامه.
السلام عليكم يا ابراهيم.
مع السلامه.